Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. In this week's video, we're continuing with our new and ongoing series entitled The QME Clinical Rounds. And in today's session, we're in session 3 of this new program. And just to review, in this program, we're talking about some common clinical conditions that you're going to encounter or have already encountered hundreds of times in your qualified medical evaluations. We're talking about common clinical conditions that seem to easily afflict injured workers as they go about their busy days engaging in repetitious and voluminous activities throughout the course of 40-hour work weeks and months and years of repetitive duties. And in session number 1 of this program, we talked about carpal tunnel syndrome and the associated pathognomonic clinical observation, and that had to do with the flick sign, the so-called flick sign. And we talked all about carpal tunnel syndrome. In our second session, we talked about an uncommon cause of lower back pain having to do with deformity of the vertebral end plates. And that was a discussion related to Schmorl's nodes. And in continuing with our ongoing program in today's session, I want to talk to you about a condition that you're going to encounter over and over and over again in your qualified medical evaluations, if not in each and every actual evaluation. And that has to do with shoulder pain associated with tendinopathy of the shoulder, particularly tendinopathy related to the rotator cuff tendons. Now, the rotator cuff tendons are not the only tendons in and around the shoulder area that can develop tendinopathy degenerative conditions, but the most common tendinopathy conditions of the shoulder are found in and around the rotator cuff, most particularly having to do with the supraspinatus and infraspinatus tendons. So in today's discussion, we want to talk about the scope of the problem. In other words, the incidence and the prevalence of shoulder pain, both in the general population and then also in the industrial setting, which includes your examinees that you're going to encounter as a qualified medical evaluator. And then we want to talk about some of the anatomy and the pathoanatomy of shoulder tendinopathy conditions so that you can get a good handle as to what actually is taking place in examinees who complain of persisting and ongoing shoulder pain symptoms that unfortunately becomes recalcitrant and stubborn to conservative treatment efforts. So it seems that by the time a tendinopathy condition takes root and takes hold of the shoulder, it's very likely that that is a shoulder that will never recover to a pre-injury normal tendon condition, because these shoulder tendinopathy conditions tend to be degenerative and unfortunately continue to plague injured workers in the industrial setting. So we'll talk about what actually is taking place on the microscopic and even the molecular level within these tendons so that you can understand the pathology that your examinees are reporting to you. And then finally, for those examinees who come to you and who report a failed response to conservative treatment efforts and who have persisting symptoms and activity limitations at the permanent and stationary evaluation, I want to share with you some of the range of options that you have available to you for providing for permanent impairment for these examinees who complain of shoulder tendinopathy conditions. And this is going to include a range of permanent impairment options for you, both under the strict application of the AMA guides and then also alternative impairment ratings under Alvarez and Guzman. And I'm hoping that you will find a couple of new ideas for rating shoulder impairments within this discussion. Okay, so with that as our introduction, let's begin today's discussion, which has to do with permanent impairment ratings for shoulder tendinopathy and specifically for rotator cuff tendinopathy conditions. Okay, so let's begin. Now, in today's discussion, I'm going to share with you two references, two research studies that discuss rotator cuff tendinopathy conditions in the industrial setting, and I'll share those references with you in just a minute. But according to one of those studies tells us that shoulder pain affects up to 67% of the population, at least in some point during the course of your lifespan. And I want to ask you, can you relate to this? Have you had shoulder pain before? Do you have shoulder pain now? You know, I seem to have shoulder pain either at a subacute or an acute level on an ongoing basis, and that's because I like to lift weights. And lifting weights seems to produce and create undue loading on the shoulder tendons, which keeps them at a near painful point most of the time. And if you're anything like me and engaged in any type of repetitive activity, especially loading of the shoulder joint, you know, it's interesting. The shoulder is a non-weight bearing joint. It's a mobility joint, and yet we insist on loading and demanding that the shoulder joint bear weight, when in fact it's a non-weight bearing joint. And we become surprised as to why the shoulder would be hurting all the time. But shoulder pain is nearly ubiquitous in the adult population, and this study tells us that at least 67%, 2/3 of people will at one point or another have some degree of shoulder pain symptoms that requires activity modifications and medical treatment. So in the industrial setting, as we're going to see as we get into these studies, you're going to encounter examinees who present to you with shoulder pain conditions, both of the referred pain type from the cervical and thoracic spine, and also of the orthopedic type, where the shoulder itself is actually presenting with an orthopedic condition, such as rotator cuff tendinopathy. Well, what are some of the common conditions that we encounter with the shoulder that bring these shoulder pain patients to us in the industrial setting? Well, common diagnoses that we encounter include the various impingement syndromes, and there's three basic types of impingement syndromes. There's a subacromial impingement syndrome, which is probably the type that you're most familiar with in both the clinical and in the industrial setting. There's subcoracoid impingement syndromes, and there are also internal impingement syndromes. Now, let's just define these a little bit. With the subacromial impingement syndrome, we see an impingement of the rotator cuff and the subacromial bursa between the greater tuberosity of the humerus and the undersurface of the acromion process. So this is subacromial. The undersurface of the acromion serves as a pinch point for the supraspinatus tendon, for the infraspinatus tendon, and for the subacromial bursa between the undersurface of the acromion and the greater tuberosity of the humerus. Remember, the greater tuberosity of the humerus is the insertion point for both the supraspinatus and the infraspinatus tendons. Well, the greater tuberosity of the humerus is also the insertion point for the subscapularis tendon, and with the subcoracoid impingement syndrome, we see an impingement of the subscapularis tendon against the coracoid process as it gets pinched against the coracoid process, again by the greater tuberosity of the humerus. Now, this is rarer in the industrial setting than the subacromial impingement syndrome, because the subcoracoid impingement syndrome requires repetitive, loaded shoulder adduction, flexion with internal rotation. So this is not a common type of movement encountered in the industrial setting, whereas it's a very common type of movement encountered in the sports and physical activity setting. So subcoracoid impingement syndrome might be something you see more in your clinical practice, but we need to be aware of this also in our qualified medical evaluation practice, as this type of impingement syndrome is prevalent in the shoulder pain populations. And then finally, with the internal impingement syndromes, we again see an impingement of the supraspinatus tendon, but this time not underneath the acromion process, but back against the posterior and superior aspect of the glenoid cavity. So the supraspinatus tendon gets impinged between the greater tuberosity of the humerus and the posterior superior aspect of the glenoid, again causing impingement and decay and pain of the supraspinatus tendon. So those are the impingement syndromes, probably the most common of which you're going to encounter in the industrial setting has to do with the subacromial impingement syndrome. But other common diagnoses include osteoarthrosis of the shoulder joint itself, particularly of the acromioclavicular joint, labral tears of the glenoid labrum, both anterior superior tears, posterior and inferior tears, and circumferential tears of the glenoid labrum. You're going to encounter soft tissue pathologies of the rotator cuff, ranging from tendinopathy to partial thickness tears, to full thickness tears, to even ruptures of the rotator cuff tendons. And of all the diagnoses that we're going to encounter in the industrial setting, approximately 2/3, 65%, of individuals with some sort will present with some sort of rotator cuff pathology in the form of tendinopathy, most commonly affecting the supraspinatus and the infraspinatus tendons. And this has to do with their unique anatomic location and their unique function in movements of the shoulder joint. Okay, so let's talk about why it is that injured workers in the industrial setting are so commonly prone to shoulder pain and shoulder tendinopathy conditions. Okay, so one of the studies that I want to share with you in today's discussion that discusses the incidence and prevalence of rotator cuff tendinopathy conditions in the industrial settings is a 2016 study published in the Asia Pacific Journal of Sports Medicine, surprisingly, entitled A Clinical Review on the Socioeconomic Impact of Tendinopathy. And in this study, they talk about how prevalent tendinopathy conditions are in the general population, not just rotator cuff tendinopathy, which, as we learn, 2/3 of people will at some point in their lifetime complain of shoulder pain associated with various tendinopathy conditions around the shoulder. Well, according to this study, they tell us that highly repetitive movements are commonly observed in daily work tasks, and this highly repetitive movements coupled with poor workplace ergonomics places workers at an increase of developing tendinopathy. And as we're going to see, it's this highly repetitive movements in awkward angles that upsets the delicate homeostasis of the internal environment of a tendon. A tendon internal environment includes tendon cells known as tenocytes, includes tendon fibers, which are collagenous fibers, or the dense fibrous connective tissue, linearly arranged collagen fibers, and then also the extracellular matrix, which is composed of water and proteoglycans, and this environment can become upset, and we see disruptions in each of those three elements. We see disruptions and changes in the tendon cells, we see disruption and changes in the collagen fibers, and we see disruption and changes in the extracellular matrix, all of which contribute to weakening the tendon unit as a whole and contribute to the downward spiral of degeneration of the tendon, which is referred to as tendinopathy. Now, they tell us that a distinction that can be made between workers and athletes, and these are two populations that generally report shoulder pain symptoms, but a distinction between these two populations is that occupational exposures, in contrast to sports exposures, typically consist of relatively low demand, low load, but highly repetitive movements over a longer period of time compared to an athletic exposure, where an athletic exposure usually involves a very high demand loading on the shoulder joint over a short period of time, such as a hockey player being driven into the boards against his shoulder and creating a high load over a short duration that causes an acute injury to the shoulder tendons or the shoulder joint itself. Whereas in the industrial setting, workers are exposed to low-level demands, low loading, but highly repetitious activities. This coupled with poor ergonomics conspire to upset the internal homeostasis of the tendon. Okay, so let's continue with some statistics from this study. They tell us that tendinopathy in workers is almost exclusively observed in the upper extremity compared to the lower extremity, the most prevalent of which is lateral epicondylitis, tendinopathy here at the elbow, at the lateral epicondyle, very closely followed by tendinopathy of the rotator cuff, which is the topic of today's discussion. They tell us that a prevalence of 2 to 3% have been observed in generalizing statistics over all populations of workers, but for specific workers such as spine surgeons and coal miners, prevalence rates as high as 18% and 41% respectively have been described. So the prevalence of tendinopathies in the industrial setting, and specifically rotator cuff tendinopathies, is largely based on the type of activity being engaged in, and that makes sense. Now, according to this particular study, age and sex do not seem to play a factor in the development of tendinopathy, and that's at least according to this study. As we're going to see, other studies suggest that age and sex do have a large impact on the rate and the development and the severity of tendinopathy conditions, with males and females having differing predilections for tendinopathy conditions at different sites throughout the body, and tendinopathy conditions tending to be more prevalent in the aged population. And a study I'm going to share with you here in just a couple minutes seems to suggest that degenerative changes of the tendons, in other words, the development of tendinopathy in the tendons, is a normal degenerative process of aging, much as the development of osteophytes around joints is a natural degenerative process of the joints. Similarly, development of tendinopathy in the tendons is a natural degenerative condition of tendons, and therefore tendinopathy conditions seem to be more predisposing to the aged population. And further, tendon injuries arise from a combination of both intrinsic and extrinsic factors, and whereas acute tendon injuries may be predominantly caused by extrinsic factors, meaning factors associated with the environment, factors associated with the job duties, etc., in injured workers who develop overuse syndromes, as in the case of tendinopathy, this is largely caused by a combination of both extrinsic as well as intrinsic factors unique to the individual. So, for example, in shoulder tendinopathy conditions, one of the intrinsic factors that we're going to encounter has to do with the shape and the morphology of the shoulder joint itself. So, for example, in considering the acromion process of the scapula, the acromion process has various different morphologies, and depending upon the morphology or the type of acromion process, can more or less predispose that injured worker to the development of rotator cuff tendinopathy. So that's an example of an intrinsic factor that contributes to the development of this condition. Now, unrelated to the shoulder, but just as an example, in talking about another tendinopathy condition outside of the shoulder, such as Achilles tendinopathy, One example of an intrinsic factor for tendinopathies of the Achilles tendon is poor biomechanics, such as limb malalignments and hyperpronation of the foot that may cause increased traction loads acting on the foot and ankle that may increase the incidence of Achilles tendinitis, increases the incidence of flexor hallucis muscle longus tendinitis, and tibialis posterior muscle tendinitis and tendinopathies. So with our injured workers, we're going to see a combination of both extrinsic and intrinsic factors at play in the development of the condition of shoulder tendinopathy, and we'll explore some of the intrinsic factors here in just a couple moments. Now, another study, a 2015 study from the Journal of Orthopedic Rheumatology, discusses the occupational risk factors for shoulder tendon disorders. Okay, so what is it about the occupational setting that seems to be the extrinsic source of so many cases of shoulder pain conditions? Well, they tell us that in 2012, and this is a bit of an antiquated statistic, but it's still illustrative for us, they tell us that 1,100,000 cases of shoulder pain conditions were reported, with a median of 9 days away from work, and this is the equivalent of 41,500 years of work lost in one calendar year, in calendar year 2012. 41,000 years of lost work time due to shoulder pain conditions. Shoulder injuries accounted for 13.6% of all musculoskeletal disorder claims, and that includes disorder claims associated with the spine. So very, very high prevalence of shoulder pain conditions in the industrial setting. And they tell us that, of course, the rotator cuff tendons are dependent on their structure and cellular organization for function and response to physiologic loading. And of course, this is not unique to rotator cuff tendons. This is common to all tendons throughout the body, in that tendons throughout the body have a normal physiologic response to loading. And as we're going to see, there's two types of loads that can be applied to tendons, and those can be broadly defined as proper loads and the opposite, which are improper loads. And proper loads have a beneficial anabolic effect on the cellular organization of tendons, whereas in contrast to that, improper loading results in an upset of the homeostasis of the internal organization, the cellular organization of the tendon, and causes a gradual degeneration and decay of the tendon. So all tendons of the body are very delicately sensitive to loading. And in the physical therapy setting, we provide loading to tendons in an attempt to provide an anabolic rehabilitative load in the form of a proper load. So that's the skill of a physical therapist, is to determine appropriate loads and to be able to skillfully apply appropriate loads. But on the other hand, improper loadings, especially applied repetitiously and over time, cause a disruption in the internal organization of tendons and leads to tendinopathy development. Tendons have a nonlinear viscoelastic response to applied cyclic tensile loads, and the precise loads, according to this particular study, which is a different conclusion than the prior study we talked about, the precise loads necessary to induce degenerative processes depend upon age, sex, and location of the body, with persons of different ages responding differently to the same applied loads, different sexes between the males and females responding differently to the same applied loads, responding differently depending upon the location of the applied load. Okay, so these factors are important considerations that go into the development of shoulder tendinopathy conditions. Okay, and then finally, the third study I want to share with you is going to begin to set the stage for some of the pathoanatomic changes that take place in the tendon, and our discussion about that in just a couple minutes. And this is a 2017 study from the British Medical Journal. It talks specifically about what are the microscopic and anatomic changes that take place in the rotator cuff tendon in persons who are developing degenerative tendinopathy of the rotator cuff tendons. So they tell us that the supraspinatus tendon in painful shoulders, in other words, they took two groups of subjects. They took a group of subjects without shoulder pain complaints, and they compared them to a population of subjects with shoulder pain complaints. And they found that those persons with painful shoulders, in examining the supraspinatus tendon, the tendon significantly increased in thickness in response to acute fatigue loading compared with subjects who had no pain symptoms in the shoulder. So they took these subjects and they applied a load to the shoulder of these subjects. They applied a repetitive load, and they took that load to fatigue, and they found that in subjects who reported pain in their shoulder, the rotator cuff itself actually became thickened in response to this loading protocol. And this has to do with the disruption of the internal cellular organization of the tendon itself. And we'll delve into that a little bit more in just a couple minutes. So they found that loading the rotator cuff to fatigue resulted in a reduced subacromial space. And that makes sense because the rotator cuff tendon is thickening, and that thickening occupies space in the narrow confines underneath the acromion process and the head of the humerus. This is the subacromial space, and a thickened tendon will occupy more space and thus be more subject to impingement syndromes, at least in up to 24 hours in those subjects who already have pain in the shoulder. So imagine this in an industrial setting. We have an employee who engages in repetitive loading and fatigue loading tasks, suffering thickening of the rotator cuff tendon, narrowing the available space in the subacromial space, and then having to resume those repetitive activities less than 24 hours later before recovery has taken place on the tendon. And it's this type of repetitive loading over time that causes a degeneration of the tendon, which is referred to as tendinopathy. Finally, according to this particular study, they tell us that thickening of the tendon due to changes in the intracellular environment, within the internal environment of the tendon, thickening is an early pathologic response that may subsequently lead to tendon compression as a secondary phenomenon. And you can imagine that as that tendon thickens within the subacromial space, it's going to be more prone to compression as a secondary phenomenon. And we're going to talk about compression on tendons here in just a moment, due to now the larger tendon occupying what is otherwise a fixed and bony and unchangeable subacromial space. So let's illustrate this phenomenon here for you so that it becomes visual for you. So what are the positions and the postures that place the rotator cuff tendons at greatest risk for the development of tendinopathies? Well, according to the British Medical Journal, repeated or sustained shoulder postures with more than 60 degrees of flexion or abduction, forward flexion or horizontal abduction, place the rotator cuff tendon at greatest risk. And then in that position with an applied load, such as holding a tool overhead, such as holding a load away from the body. Okay, so with the shoulder in this position at 60 degrees of flexion or abduction, and then applying a load to the joint and to the tendons, seems to be the worst position for the rotator cuff tendons. And therefore, the height of the hands in relation to the shoulder determines the shoulder workload. So you're going to want to interrogate and interview your examinees about repetitive activities approaching shoulder height at and above shoulder height. from 60 degrees to 120 degrees of arm abduction seems to be the position that creates the greatest mechanical pressure on the tendon from the acromion above. Imagine that, from the acromion above. So here we're talking about the subacromial impingement type of shoulder condition. And I want to perhaps give you a little visual illustration of what happens to the rotator cuff tendon when the arm is between 60 and 120 degrees of elevation in either flexion or abduction. We have the rotator cuff as depicted here by this strand, and the rotator cuff comes out of the supraspinatus fossa and comes across the head of the humerus as depicted here by the tips of my fingers, and attaches here to the greater tubercle down on the head of the humerus. Now, when the arm is in 60 to 120 degrees of arm elevation, the rotator cuff tendon now becomes under tensile load, and I'm demonstrating tensile load by pulling on this tendon. Can you see that I'm pulling on the tendon? So I'm applying tensile load to the tendon. Well, in addition, at 60 to 120 degrees of elevation, the rotator cuff tendon comes up underneath the surface of the acromion process here. So first it's under tensile load, and I'm sustaining the tensile load, and then here's the head of here's the undersurface of the acromion process, and the tendon gets raked up against the undersurface of the acromion process as it undergoes scraping on the undersurface of the acromion process. So we have a combined tensile load combined with a compression load here, compression load, as the rotator cuff is compressed under tensile load against the undersurface of the acromion process. And this particular position and this particular maneuver, performed repetitively, causes decay and tendinopathy and upset of the internal cellular structure of the tendon, leading to chronic and painful shoulder conditions. Okay, so doctors, so when we consider both the extrinsic factors that contribute to the development of shoulder tendinopathy and the intrinsic factors that contribute to the development of shoulder tendinopathy, what we're going to see is that, at least with regards to rotator cuff tendinopathy, employees who engage extrinsically in the extrinsic activity of arm elevation between 60 and 120 degrees, okay, which is many job place activities. I mean, think about a bus driver turning a steering wheel with his arms out here at approximately 90 degrees of elevation. Or think about a conveyor belt worker with their arms down here at approximately 75 degrees of arm elevation. Or think of a painter with their arm at greater than 90 degrees of arm elevation painting walls, or tree pruners, or many activities, many job titles would involve activities, shoulder activities, between 60 and 120 degrees of arm elevation. Well, due to repetitive activity within this high-risk range, causes over time some tensile loading and compressive loading intrinsically against the undersurface of the acromion. So loading the rotator cuff tendon below 60 degrees is less of a risk because it involves tensile loading only in the absence of compression loading. It's as the arm comes up to 60 degrees and up to 120 degrees, in addition to the tensile loading, we also get compressive loading of the tendon on the undersurface of the acromion. Here's the undersurface of the acromion, and the tendon then comes underneath the undersurface of the acromion under tight loading, tensile loading, and there's compression here at the interface of the supraspinatus tendon with the undersurface of the acromion. So this is an intrinsic factor that contributes to the development of this tendinopathy condition, and this is rampant and prevalent in the industrial setting because so many job activities involve this particular range of shoulder motion. Okay? Now, in our next session, we're going to go into the anatomy of the tendon, and we're going to see in degenerative and tendinopathy tendons what is actually taking place that causes a thickening of the tendon within this subacromial space. The thickening of the tendon, and I'll just give you a little advanced preview, has to do with changes in the internal environment of the tendon, changes involving the tendon cells, the tendon fibers, which are collagen fibers, and the extracellular matrix, and we're going to see changes in each of those three components of the tendon, each of which contributes to the progressive degeneration of the tendon, leading to chronic pain and activity limitations, and ultimately, as we're going to discuss, to a final permanent impairment rating to represent the examinee's ultimate loss of function of the shoulder. So I look forward to being with you on our next session as we go into anatomy and pathoanatomy of the rotator cuff. And for now, this is Dr. Perry Carpenter wishing you best of success in your career as a qualified medical evaluator.